I'm sorry for the delay in 5 minutes. We've had some technical difficulties trying to get the audio going. If you can hear us clearly, if you could just send us a quick text, we should be ready to go. Welcome to the webinar. Thank you for signing in. My name is Amita Reddy. I am the Regional Epidemiology Program, Acting Program Manager here at Communicable Disease Service at the Department of Health. We will be starting the webinar. Here is a little bit of information about today's webinar. Today's program is approved for 2 public health credits and 2 nursing contact hours. I will go over the specific details on how credits will work at the end, but for those people watching as a group, please send in a group sign-in sheet for each location that you're at. The technical info, we will take questions at the end of each session, and we will have a general question and answer session at the end. To ask a question, you can type a question into the questions or chat box at any time. If we don't have time to answer all of the questions, I will send answers out after the webinar. For those of you with access to NJLMN, the presentation slides are posted under Practice Exchange. Please note that a few slides were updated yesterday to reflect the new Zika guidance that was released on Monday this week. Kim will be discussing the updates later in the presentation, so if you've printed out slides before yesterday, you may be missing a couple of slides, but they are available on Practice Exchange and you could always go down and download them. We will be recording and archiving today's webinar. There will be no credits offered for watching the recording, however. As a reminder, I am going to go over where we will be seeing the webinar. So if you go on to the Department of Health web page, you will be clicking on Public Health, and this will bring you to the orange screen. When that screen opens up, you could click on Communicable Diseases, and the next page will bring you to our new and improved web page, and clicking on that Education and Training tab on top will take you to our Communicable Disease Forums page. Please note that it may be a week or so for it to be posted, and the direct link will be sent out on where you can access the information. Here is the page for Communicable Disease Service, and if you hit on Education and Training right on top, it will bring you to the CDS training resources, and the direct link is right here. A couple of programmatic notes. A few zoonotic disease updates. First, the zoonotic disease team has posted updated disease chapters. In addition, many of the disease websites now include an investigation worksheet. These worksheets are not required for you, but may help you collect relevant information during a physician and or patient interview. The updated chapters and investigation worksheets for the zoonotic diseases can be found on the disease-specific websites, and the links are attached here as well. This is our agenda for today, and our first presenter will be Kim from Vector-Borne Diseases. We will then continue on to the new Communicable Disease Reporting and Surveillance Systems update provided by Della Stuti, and following which we will have Deborah Gleisner from Sexually Transmitted Diseases, who will be reporting on guidelines and investigation of sexually transmitted diseases. So a couple of housekeeping. Nurses, the participants must attend the entire session in order to earn contact hour credits. Attendees must participate in all learning activities. Verification of participation will be noted by webinar attendance reports or group sign-in sheets and completion of an online evaluation. Participants cannot miss more than 5 minutes from a 30-minute session or 10 minutes from a 60-minute session. Participants must complete the online program evaluation and include your name and email address to receive nursing certificates. Also, there has been no commercial support in influencing the planning or the educational objectives and content of this event. There has been no influential relationships disclosed by planners or presenters which would influence the planning of this activity. If any arise, an announcement will be made at the beginning of the session, and there has been no endorsement of any product by the NJSNA or the ANCC associated with this session. That being said, I am going to turn over the presentation to Kim Cervantes. Kim will be talking about the vector-borne disease investigation updates. She is the vector-borne disease coordinator and will be speaking about highlights of the Zika guidance that was released this Monday as well.
All right, thank you, Numisa. Good morning, everyone. Okay, just make sure my screen is being shown here. Okay. All right, so my talk this morning, I'm going to focus on investigational updates related to 2 mosquito-borne and 2 tick-borne diseases. I'm going to talk about Zika and highlight the new testing recommendations, the new dengue subgroups, some investigation guidelines and new resources for Lyme disease, and a brief update on Powassan. So I'll start with Zika. This map is probably familiar to many of you. It's the interactive CDC map showing areas with risk of Zika. So these 2 graphs are showing the number of persons tested for Zika by month at the top and the number of Zika cases at the bottom. So in 2017, New Jersey tested an average of 250 people each month. You can see that we tested an increased number in May and June, both over 300 persons per month, and of course local health departments approved most of those test requests. We've only identified 10 Zika cases in 2017, and you can see in the bottom chart how our case counts have really dramatically dropped off. So these 2 graphs are reflecting consistent travel patterns of New Jersey residents to countries designated at risk for Zika, but where disease transmission is much lower. 2017 is looking very different than 2016 for Zika, and I'm going to show a few slides that describe this. So this slide is showing the number of persons approved for Zika testing by county, comparing 2016 with 2017. And this is as of July 6th, so it's roughly about half the year. And you can see that the total number of persons tested in 2017 is about half the total number that were tested in all of 2016. So looking at testing numbers by county, the counties highlighted in red have approved higher numbers in 2017 than the roughly half of the 2016 numbers we would expect to see. For example, Sussex County has approved more persons so far in 2017 than were approved in all of 2016. This slide is showing New Jersey Zika cases by county and year. There have been 10 Zika cases in 2017 compared to 239 previously, but you can see that the cases are still distributed in roughly the same counties as the ones having the higher case counts reported in 2016. Okay. So, sorry, I think I skipped one. Okay, this is showing our cases by country of exposure in year. So in 2016, there was a clear predominance of travel exposures to the Dominican Republic and to Puerto Rico. In 2017, there is no similar predominance of country. Of course, the case count is much lower, but they're sort of spread out and there is no clear predominance of 1 or 2 particular countries. Looking at testing for pregnant women, to date, 81% of women approved for testing in New Jersey have been pregnant, and that's over 3,300. In 2017, nearly 95% of pregnant women tested were asymptomatic, and that'll be important in light of our new testing recommendations. So, and I know this slide is busy, but we'll walk through it, but we know there's challenges with the lab tests we have for Zika. There's additional challenges in interpreting test results based on the current state of the Zika outbreak, in which disease transmission is dramatically lower. So let's look at a sample lab test. The left side of this slide is showing a disease that is common, with 40 out of 100 people tested, shown in red, having the disease. The people in blue do not have disease. The lab test used in this example has 98% sensitivity and specificity, which is very high. So looking at the yellow box on the left, 1 out of 40 people who test positive does not actually have the disease. So that's a 3% false positive rate. On the right side of the slide, the disease in question is rare, with only 1 person out of the 100 having the disease. So looking at the yellow box on the right, 2 of 3 people who test positive do not actually have disease. So that's a 67% false positive rate. As you can see, as disease incidence decreases, the risk of false positive results increases. In addition, in May, CDC issued a health alert describing persistent IgM antibodies in certain populations, including pregnant women. Since we're in the second year of the Zika outbreak, it may be difficult to tell when someone was infected, and if it was prior to a current pregnancy, particularly in persons with repeated exposures. So in light of those challenges, new this week on Monday, for any asymptomatic pregnant women with a recent exposure, CDC is no longer routinely recommending Zika testing. However, testing can be considered given patient preferences, clinical judgment, and a balanced assessment of risks and expected outcomes. CDC is encouraging a shared provider-patient discussion of these risks and balances to talk about what their exposure was, how long was their exposure, what was the level of disease transmission in the country at that time, what personal protective measures did they take to prevent against mosquito bites, did they have exposures in a Zika-affected area prior to the current pregnancy as well as during the current pregnancy? Would there be any reproductive decisions made based on test results? And discussion of the risk, the higher risk of false positive results. After that discussion has been had, if the clinician and patient still desire Zika testing, then of course it can be ordered. But they are recommending that the clinicians have that discussion before requesting Zika testing for asymptomatic women. So this change will reduce the possibility of false positive results and of having positive results reflecting infection prior to the current pregnancy. It's hard to know how many physicians will request testing in light of the new guidelines, but we do expect the overall testing volume to dramatically decrease. And with that decreased maternal testing, it will be increasingly important for pediatricians to assess infants for congenital Zika. For asymptomatic women with ongoing Zika exposure, IgM testing also has very limited value given the persistence of the IgM response. NAT testing, or PCR, is recommended in this group 3 times during pregnancy. We don't see many women in this group, as it mostly applies to women who are living along the border with Mexico and who travel back and forth on a daily or weekly basis. For symptomatic pregnant women, CDC still recommends Zika testing, but with concurrent PCR and IgM testing extending 12 weeks after symptom onset. So this is a change primarily for FEL, our public health lab. It's also a change for physicians who are ordering tests through commercial labs. We really need to get the message out that they need to be ordering both PCR and IgM for symptomatic pregnant women. And having the extended window for the PCR testing may provide more pregnant women with a definitive diagnosis. Some other updates. This should make things a little bit easier. With the decline in prevalence of Zika virus disease in the Americas, the criteria for evaluating a travel exposure for all pregnant women is now considered to be any area at risk for Zika virus transmission, or basically all of the purple countries. Formerly, for asymptomatic pregnant women, it was a subset of those countries, and specifically the countries with a CDC travel notice for Zika. So that is a change. A travel exposure would be considered any of those purple countries. The interpretation of Zika lab results has also been updated. When interpreting lab results, CDC is recommending that all lab tests be considered as a whole. So looking at PCR test results on both serum and urine and serological testing, looking at what was positive, what was negative, looking at that all together before making an interpretation of what that lab result means. In some cases, a second specimen may be needed to confirm that interpretation. And it may be, for serologic results, it's not usually going to be possible to determine the timing of infection. At this point, we have not received information that would change how we classify Zika cases in CDRSS based on the updated lab interpretation. So for now, we will continue to follow the existing case definition, and of course, if that changed, we'll let you know. CDC has developed several educational materials for healthcare providers and pregnant women. There is a COCA call today at 2 p.m. I've put the link out there, and we've tried to distribute that widely so that as many people as possible can listen to that call. We're hoping a lot of New Jersey clinicians can attend that call as well. We will be issuing New Jersey-specific guidance next week to clinicians and, of course, to local health departments. And in the interim, if a provider is requesting Zika testing, we're recommending that you send them this one-page when to test for Zika virus shown here on the screen fact sheet. It's a very sort of easy way to eyeball who should be tested, who should not. It clearly contains the new recommendation that asymptomatic pregnant women are not routinely recommended for testing. If after that's sent to the provider, if they have reviewed the risks and the expected outcomes with the patient and would still like testing, then definitely approve the test request as long as they meet the other travel and testing window criteria. So we often get questions about Zika testing approvals. Specimens have to be collected within 12 weeks of last exposure, and this applies to everyone who is being tested for Zika. It's primarily due to the limitations we have with the serologic testing, where IgM antibodies tend to wane after about 12 weeks in most people, although we have seen data now that shows persistence of IgM. For persons who are symptomatic, symptoms need to have developed within 2 weeks from the last exposure, because if they develop after that 2 weeks, it likely isn't Zika. Sexual exposures can be confusing and are dependent upon dates that may not be easily obtainable. It's particularly important to capture this information if testing eligibility will be based on the sexual exposure and not on the travel exposure. So a travel exposure is any unprotected sexual contact with someone who is exposed to Zika and is potentially infectious. So for exposed men, semen is considered potentially infectious for 6 months. In order to determine if a sexual exposure is valid, we need to know where the partner traveled to and when. We also need to know the date of the first unprotected sexual contact with the partner after that person's exposure, and most importantly, the last date of unprotected sexual contact before the test request is made. Ongoing exposure doesn't allow us to calculate that time frame. The Public Health Lab is reviewing every test request, every SRD1. If we don't have the dates of the unprotected sexual contact, then the specimen may be rejected. Okay, so we're going to do an example and a poll question. So John traveled to the Dominican Republic from January 15th to the 30th with his pregnant wife, Jane. Jane developed a fever and a rash on May 29th. On June 1st, Jane's obstetrician requests Zika testing. Jane traveled over 12 weeks ago, so would not be eligible for testing based on her travel exposure. Jane does report having ongoing, unprotected sexual contact with John. Okay, so we are going to do our poll question. So based on that information, is Jane eligible for testing? Okay, so let's see if we can close the poll. Okay, not sure we're there. But the answer is that we need more information to find out. Oh, there's the bars. Okay. All right. So 69% said yes, just 18%. Okay, so the answer is we need more information. We need to find out when Jane's last unprotected sexual contact was. Okay. All right. So after further investigation, she reports unprotected sexual contact from January 15th, the date of arrival in the DR, through May 25th, which was the last time before seeing her physician on June 1st. John's semen would be considered potentially infectious for 6 months from his last exposure on January 30th, which would be through July 30th. All right, so based on that information, is Jane eligible for testing? Okay. All right, so let's see how we did here. Oh, excellent. Okay. Since Jane had unprotected sexual contact with John on May 25th, this is within John's infectious period and would be considered a sexual exposure for Zika. Her symptom onset on May 29th is within 2 weeks, and the date of test request, June 1st, is within 12 weeks of the last date of her sexual exposure on May 25th, so the testing window is valid. And yes, this request for testing should be approved. And I know there's an awful lot of dates going on here, but you all got 95%, so excellent. So I'm going to go over some tips on case investigation and the documentation we need in CDR-Assess. First, as soon as you have symptoms, select a subgroup on the Patient Info tab. The signs and symptoms and the risk factors are tailored to each subgroup. So the rest of the case will be easier to enter if you select the subgroup first, because then you won't see symptoms or risk factors that you don't need. Timely investigation of Zika cases, and again, I'm not necessarily talking about people who are requesting testing. I'm talking about cases. So these are cases that have confirmatory labs and that we're classifying as cases. So timely investigation is important to identify where they were exposed, which of course you would know if you've already approved the testing request, but from a commercial lab, because we don't want to see cases that don't have a out-of-country exposure. We want to determine the pregnancy status so that we can enroll them into the U.S. Zika Pregnancy Registry and ensure a follow-up of mom and baby, and we need to provide time-sensitive patient education. So the Zika Patient Information Worksheet that we've been using contains most of the information needed to classify a case. And most of that information can come from the healthcare provider. However, it is also important to provide education to the patient. All returning travelers should be instructed to prevent mosquito bites for 3 weeks after travel to prevent the spread of virus into the New Jersey mosquito population. In addition, education on preventing sexual transmission should be provided with additional precautions if the patient or their partner is pregnant. We're also asking that you ask the patient if any household members are ill with symptoms of Zika. Ill household members, if they don't have a travel or sexual exposure, may indicate local mosquito transmission. In this case, they should be advised to see a healthcare provider for Zika testing, and if local transmission is suspected, please notify CDS right away. In that scenario, we would be working with DEP to coordinate vector surveillance and control activities in conjunction with the county mosquito control agencies. And similar to the varicella investigation guidelines, CDC is asking that a follow-up call be made to the patient 14 to 21 days after symptom onset to confirm if any household members did become ill. I know this is a new request, but it is only for Zika cases, of which we only have 10 in the entire state in 2017. And the testing approval volume should be dramatically decreasing, so we're hoping this won't be too cumbersome. Risk factor and symptom dates are important to capture to determine the exposure as well as the eligibility for testing. For a travel exposure or someone who's relocated to the U.S., we need the country written in the attribute field and then the dates next to the risk factor. not necessarily entered into the case comments field. For a sexual exposure, we need the sexual transmission risk factor selected with dates, and we also need the sexual partner's travel risk factor selected with the dates and the location of the partner's travel. For a pregnant woman, even though you're entering pregnancy information under the clinical info tab, we also need the risk factor exposed during pregnancy checked. And this is because pregnancy information on the clinical info tab is person-specific. So this will change once the person is no longer pregnant. So to capture the data on Zika cases in pregnant women after the pregnancy has ended, we need to have it captured in the risk factor section. CDC has asked us for 2 additional indicators on Zika cases. And again, these are just cases, not persons tested for Zika. CDC is measuring the timeliness of investigation and the timeliness of providing control recommendations. So we've included a description of this in the new Zika chapter, which should be posted next week. And we're basically asking that you document this in the case comments field. I've included an example here. If you've provided a control recommendation to the patient or to the physician, just to document that and the date. And that way we can report on those indicators to CDC. And CDC is using a within 48 hours as their benchmark for each of those 2 indicators. So we're in the process of updating several resources to reflect the new testing recommendations. We'll be updating our testing guidelines and algorithms, the patient information worksheet, and the delivery packet. Currently online, we do have a recently posted Track When You're Back flyer that contains important messages for travelers returning from areas with mosquito-borne disease like Zika, Dengue, and Chikungunya. Could certainly be sent to a patient as part of patient education. And we have a draft Zika investigation chapter. We were hoping to get that online this week, but then CDC revised all their testing recommendations, so we'll be taking one more look at that and hopefully getting that up next week. Okay, so I'm going to move on to dengue. These maps are showing areas with dengue transmission, and the darker blue are the countries that have more frequent transmission. And of course, you can see that the distribution of dengue is very similar to the distribution of Zika. The 2015 case definition divided dengue cases into 3 subgroups based on clinical presentation. New Jersey added the subgroups into CDRSS earlier this year, and we reclassified all of our 2016 cases before submitting our final counts to CDC. All of the subgroups require symptoms. The dengue-like illness subgroup only requires fever, which can be either self or physician reported. Dengue requires fever and 1 additional symptom, and of course severe dengue has the very severe presentations that we don't commonly see, thank goodness, in New Jersey. So all cases of dengue have to meet the clinical criteria for one of the 3 subgroups. If you have a case without symptoms, that would be not a case. The type of appropriate lab test will determine if the cases are classified as confirmed or probable. And possible is a new case status for dengue. Possible cases need to meet the clinical criteria for one of the subgroups, and they have to have an epi linkage, which is usually travel to a country with dengue transmission, but they do not have acceptable labs. So for example, a clinically compatible case with a travel exposure and only an IgG result would be classified as possible for the respective subgroup. And we do have a new dengue chapter posted online now, reflecting those new case definitions, and we'll be posting an investigational worksheet in a few days to assist with interviewing. When Zika testing is performed after a positive IgM result for Zika, a PRNT or a plaque reduction neutralization test is run for antibodies against both Zika and dengue. If the PRNT is positive for dengue, it will create a dengue case in CDRSS. So currently, CDS is reviewing and classifying these cases. not reported to CDC, and they are not included in New Jersey case counts. Similar to Zika, timely investigation of dengue cases is important to identify the source of exposure. We want to make sure that there is a relevant travel history, and to prevent the spread of the virus into the New Jersey mosquito population by providing the patient education. The message is the same as the message for Zika, basically to prevent mosquito bites for 1 week after symptom onset, or as a general rule, 3 weeks after travel. Okay, a few things on Lyme, ticks and Lyme. We have another poll question, and let's see if we can get that launched. The question is, what bacteria causes Lyme disease in the United States? All right, 89%. Borrelia burgdorferi, 4% B and C. Okay, the 4% are correct. The correct answer is D. Borrelia burgdorferi is the primary bacteria that causes Lyme disease, but Borrelia mayonii is a new bacterial species recently found to cause Lyme disease in people who live in the upper Midwestern U.S. The new bacteria has not been reported in New Jersey, so kind of a trick question. And this map, of course, is just showing the distribution of Lyme disease cases, and as usual, New Jersey is completely covered. So in terms of case classification for Lyme disease, the only symptoms that are relevant for case classification are an erythema migrans rash, or the EM rash, or a late-stage manifestation which is not explained by another etiology, of which there are 3 groups, and they have very specific inclusion and exclusion criteria. The 3 groups pertain to the musculoskeletal, nervous, and cardiovascular system. Now, many other symptoms may be present in someone with Lyme disease, including fever, arthralgia, fatigue, etc., but they do not meet the clinical criteria in terms of the case definition. Appropriate labs for Lyme disease are a culture, which is rarely performed, a 2-tier test, which is a positive or equivocal EIA or IFA antibody test, followed by a positive IgM or IgG Western blot for Lyme disease, or a single IgG Western blot for Lyme. So the EIA or IFA tests are measuring the body's antibody or the immune response to the bacteria that causes Lyme disease. The Western blot is looking for antibodies that the body makes against different antigens that are part of the Borrelia burgdorferi bacteria. There are specific criteria for the Western blot that require a certain number and specific bands to be positive for Lyme. For example, the criteria that requires at least 5 IgG positive bands reflects the fact that people with Lyme disease have at least 5 detectable antigens. And importantly, it's very important to know that any IgM Western blot results are only valid if the specimen was collected less than 30 days after the symptom onset. So knowing a date of symptom onset is critical when evaluating if the lab test is appropriate. New Jersey is considered a high incidence state for Lyme disease. I'm sure everyone knows that. CDC's case definition now distinguishes between high and low incidence states. So some parts of the case definition don't apply to persons exposed in New Jersey. They are listed in our chapter just in case you receive a report of someone known to be exposed in another state. But unless you know otherwise, assume exposure occurred in New Jersey and follow the high incidence state guidelines. So what that means in New Jersey is any physician-reported erythema migrans or EM rash is a confirmed case, as is a case with at least one of the late-stage manifestations accompanied by appropriate labs. A probable case is one that doesn't meet the clinical criteria for a confirmed case, but does have appropriate labs and the physician has diagnosed the patient with Lyme disease. So for probable cases, as long as there are appropriate labs and a physician diagnosis, no symptoms are needed to classify the case. although we would like them entered into CDRSS. Possible cases have appropriate labs, but no clinical information provided by the physician. So this case status is for when you receive a lab report, you make attempts to reach the physician, but they don't respond. After 3 attempts to obtain information from the provider, you can close the case as a possible case. If the provider does respond with information, but the symptoms don't meet clinical criteria, for example, fever and arthralgia, and if there is no specific Lyme disease diagnosis mentioned, then it would be classified as not a case. If the physician specifically states that the patient doesn't have Lyme disease, it would also be classified as not a case. And again, possible Lyme disease cases are not reported to CDC, and they do not appear in the New Jersey case counts. So Lyme disease is one of the few communicable diseases where faxing a form to the provider is entirely appropriate for case investigation. We have updated the CDS-14 Lyme disease case investigation form to try to make it easier to get the information you need to classify the case. We've revised the symptoms to more closely align to the case definition, and we've added a specific question to try to capture that physician diagnosis of Lyme disease. When a patient has a late-stage manifestation, the physician may not know the exact onset date and will leave it blank. However, as I mentioned, we really need at least an approximate onset date just to assess if the validity of an IgM Western blot test. So we've added a question on the form to ask if when the exact onset date is unknown, to at least specify if it's greater than 30 days prior to specimen collection. So if we can collect that, we should be able to accurately classify many more cases that only have an IgM Western blot instead of the IgG. There is rarely any need to interview a patient as part of a Lyme disease investigation. The symptoms are physician reported, so there's really no additional information that can be provided from the patient. The new chapter is posted online now. The form is going through our process and will be online shortly, but you can see the new form on the last page of the chapter, which is online. Okay, so we'll do another example here. So Bob has fever, malaise, myalgia, and arthritis. He has a 2-step test with a positive EIA antibody test and a positive IgM Western blot. Okay, so we're going to do a poll question. How would this case be classified? Okay. Well, 28% are correct in that we need more information. That seems to be an ongoing theme. We need more information. For symptoms, we're only looking for an EM rash or a late-stage manifestation. So the fever, the malaise, and the arthralgia, while we want to document these in CDRSS, they're not needed for case classification. Now, arthritis might meet the criteria, but we need to know if it was characterized by recurrent brief attacks over weeks or months of objective joint swelling. The 2-step test is good, but we can't tell if it's an appropriate lab test because it's an IgM Western blot and we don't have an onset date. So Dr. Susan reports that the arthritis was not preceded by recurrent brief attacks of joint swelling, but she is diagnosing the case as Lyme disease. She reports an onset date of arthritis 2 weeks prior to specimen collection. All right, so we're going to do another poll based on this information. How would the case be classified? Okay, 49% said probable, so about half are correct. The correct answer is probable. Arthritis without having been preceded by the recurrent brief attacks of joint swelling does not meet clinical criteria for a confirmed case. Since the onset date is within 30 days of specimen collection, the labs are appropriate, And we have a physician-diagnosed case of Lyme disease, so that would make it a probable case. Okay, and finally, just a very brief update on Powassan. This map is showing Powassan cases from 2006 to 2015, and there were 3 reported cases in New Jersey during that time. You can see, obviously, the clustering in the Northeast and, again, Upper Midwest. So Powassan is a rarely reported tick-borne arboviral disease. Most cases in the U.S., again, are concentrated in the Northeast and Great Lakes regions. The symptoms are similar to other arboviral diseases with fever, headache, vomiting, weakness, confusion, seizures, and memory loss. And long-term neurologic problems can also occur. Most of the reported cases to date have been neuroinvasive, but because there are so few cases, milder cases have likely been undetected and unreported. Commercial testing is not widely available, so physicians have to be aware of Powassan, and they have to make the extra effort to contact public health for testing. CDS can approve testing for Powassan at CDC, and I've included a couple headlines. You all know that there's been a lot of media coverage on Powassan this year, and as a result, we have had a considerable number of test requests from clinicians. We've approved 25 specimens for testing at CDC, and that compares to only 3 persons tested last year. So we definitely saw a market increase. And this map is showing provisional Powassan case counts for 2017. 10 cases have been reported to date, all neuroinvasive, with 1 death in Rhode Island. And there was 1 case reported in New Jersey from Sussex County. We still have pending lab results for several individuals being tested. I'm going to skip that slide. On the health education front, we've been really busy. Some of you may know Krista Real. She's our health educator that works with us. And this year we did initiate our Track When You're Back campaign to remind travelers, again, returning from areas with mosquito-borne diseases, to track time and symptoms when they come home, even if they're not feeling sick right away. The key messages are to avoid those mosquito bites for 3 weeks, to check for symptoms of illness, and seek medical care if you feel sick. There are also special precautions for travelers to an area with Zika virus that don't tend to apply for persons concerned about dengue or chikungunya, for example. So we do have this infographic flyer posted online and a brief video discussing these messages, which I believe is going to be posted in the next day or so. Our Tick-Borne disease brochure was updated this month and posted to our Tick-Borne disease web pages, and we are in the process of printing brochures. We've had a lot of requests for tick-borne disease information, so those should be available soon, along with the popular tick safety cards. We'll have more of those also. There's a new tick-borne disease prevention video outlining how to protect against tick-borne diseases and how to safely remove an attached tick, which again should be up within the next week or so. And lastly, we're excited to announce our Tick-Borne Disease Basics PowerPoint presentation, which includes a pre- and post-test, a program evaluation form, and a program report form. So this presentation is going to discuss New Jersey's specific statistics on endemic and emerging tick-borne diseases, as well as prevention information and FAQs. So later next month, we'll be holding a webinar training for HERCs and other local public health professionals, and provide the participants with the slides and program materials so that they can deliver presentations on tick-borne disease in local communities. Link's message will go out announcing that training, so please keep an eye out for that. And with that, I think I may have time for a few questions.
Thank you, Kim. If anyone has questions regarding the presentation, please type it in the question box.
Okay. All right, so I see a few questions. Question is, if a pregnant patient arrives from the Dominican Republic, should testing be done as it was ongoing exposure? This is one of those shared provider-patient discussions. If the patient was in the Dominican Republic, they would definitely be classified as someone with ongoing exposure, where PCR testing would be recommended for 3 times during pregnancy. If someone relocates here prior to delivery, and we do have a high number of women who do that, as long as the risks and benefits of testing were discussed, and the risks of then that would be an acceptable test request. Question, how affected will the baby be if mom is exposed and or becomes infected with Zika in the last trimester? That data is not yet available. The data that has come out definitely shows a higher risk for congenital Zika for moms exposed in the first and second trimester. However, they do have cases where mom was exposed in the third trimester as well. That's particularly relevant for, again, women with ongoing exposure in terms of perhaps the timing of those PCR test results. Some clinicians may only want to test in the first and second trimester. Other clinicians may prefer to test once per trimester. But in terms of the risk level for exposure in the third trimester, I don't think that information is known yet. Oh, questions are coming fast and furious. Can you expand the box maybe then? Okay, our new, let's see. Okay, so the question that you get a worksheet from a provider for Zika testing, how would you know if the discussion has been had? That's exactly what we're trying to figure out, and we will be included in our New Jersey guidance sent out next week. Ideally, if someone sends in a request for testing, I think the ideal solution would be to have a conversation with the provider, make sure they're aware of the new recommendations, why they're changing, the new challenges with the lab test, and to go over what the CDC is recommending that be discussed. In reality, we know that maybe not everyone would be comfortable having that discussion with providers. So I believe we're going to be looking at developing both some talking points to have those conversations, as well as something in writing that could be sent. So again, until we have our guidance next week, we are recommending that one-page when to test for Zika fact sheet could be sent to the provider. If they make a follow-up request after receiving that, at this point I would go ahead and approve the test as long as they meet the other criteria. In light of the new CDC Zika testing recommendations, how is cell approval for testing? Again, I think I addressed that. For anyone, again, who is symptomatic, there's basically no change. There will be changes on the cell side in terms of the testing that they order, but that would be on their end. And for an asymptomatic pregnant woman, again, at this point, send that one page, when to test for Zika. If the provider reaches out again saying, yes, they're aware and they still want testing, then at this point, go ahead and approve the test request. Information will be sent out to physician offices. We did send out information yesterday and the day before with the abbreviated fact sheets and a link to the MMWR. We really wanted to get the message out for the COCA call today, which is geared towards clinicians. I hope some of you can attend as well. And we really did our best to try to get that COCA call message out to clinicians. We sent it out through AAP to pediatricians, through ACOG to obstetricians. We sent it through LINK. The regional EPI program forwarded it to all of you. So we also faxed it to providers who ordered Zika testing in 2017. So we're hoping they can really get onto that call. But I think we'll have to see in terms of the impact of the total volume. Okay, I think that's all I have for now, but I'll be happy to answer some questions at the end.
Thank you, Kim. We will answer questions towards the end. If we have some time, we'd like to go ahead with the presentation today. So send your questions if you have them, and if we can't get to it today during the webinar, we will be sending out answers after the webinar is complete as well. Our next presenter is Della Struti. Della will be talking about the new Communicable Disease Reporting and Surveillance System. Della is our CDRSS coordinator and trainer here at the Communicable Disease Service.
Good morning, everyone. My name is Della, and I'll be covering updates on the new Communicable Disease Reporting and Surveillance System. The agenda will cover a timeline for the new redesigned system. I'll review some of the new functionalities of the system, along with going over a testing and training plan, and then some changes impacting the local health department. So the following is an estimated timeline. We experienced some delays to our timeline from last year due to personnel changes, but we are currently in the process of completing programming, user testing, and bug fixing. We hope to complete that by the fall of this year, and then we will begin training for the new system in fall and winter of later this year. So just to go over some of the functionalities again, so the new system uses the entire screen, so there's more real estate. You'll be able to see the screen, zoom in more, customize the screens, also accessible on tablets, and so the screen size automatically adjusts to the device that you're using. And then to review some of the functionalities, so we now have internal messaging. This means that users can message each other within CDRSS without having to email separately. This will facilitate easier communications and keep your CDRSS-related communications in one place. In addition, users can now have multiple profiles under a single user ID. So this will be very useful for public health staff that work in different jurisdictions or facilities. This way you can keep your caseload separate instead of having your pending cases filling up with all of your jurisdictions. Also, you'll now be able to view your recently viewed cases easily from the menu, which I'll show you screenshots a little later. And then you can also do both person and case searches with different variables and customized features. So you'll include the option to list multiple cases or person IDs in the search box, which will be very useful for merges that you guys see a lot of at the local health level. And then lastly, just some of the other functionalities. So when you search by the name, the system will search the first and last name, both when you're doing the person and case search. Okay, just to show you what the internal messaging system will look like, you'll be able to access it from the top right menu, and then the system will search with all users in CDRSS, so you can easily send them a message. This shows the screen that you'll see when you have a multiple profile set up with your user ID. So when you first log in, if you have multiple profiles set up, then you'll be able to select which profile you want to go into and then enter your password. And every time you switch your profile, you'll have to enter your password so that you can access the various jurisdictions that you have access to. And the recently viewed cases that I mentioned, so this will display the last 5 cases that you've accessed in CDRSS, so you don't have to redo the search. You can easily access them from the top right. And it'll show the case ID number, the disease name, and also the patient's first and last name. Okay. So going into some more details regarding the case. So the new system features sections instead of tabs. So this way you can view the entire case on one page. It'll also allow you to save individual sections while you're entering the information without exiting the case. So no more 45-minute time lock, so you won't lose the data, because the sections will now be saved each section at a time. It's not like now where you have to enter all of the information and then submit. And multiple users can also view and edit the same case at the same time. Only the section that you're utilizing will be edited, will be locked by the user. Other sections will be available to other users to review or edit. In addition, each disease will be customized per the disease requirements with a section we call the disease-specific section. I'll go into more detail in that as well. But for example, if a chlamydia or a Lyme disease case doesn't require immunization information, then immunization section will not be displayed in the case. So these diseases will be customized based on the requirements from our disease primaries. And then also risk factors, signs, and symptoms will now have definite responses. To show you what the sections will look like, instead of having the tabs at the top now, you'll be able to see the sections similar to this screenshot, listing the section name, and then when you click on it, it'll expand the information for that section. So when I mentioned the sections based on disease, this is where you will be able to customize, our disease primaries will customize their diseases. So if immunization information, like I mentioned, isn't required for salmonella, then you won't see it for that case and disease. This is the format for our new signs, symptoms, and also risk factors. So we'll now have a new feature called status. So it'll be a drop-down which identifies the specific response, and then the remaining functionalities will be the same with the name of the sign and symptom, and then allowing you to identify the attribute along with the onset and resolution date. So going into some more good news, so cases created manually will now follow the electronic case creation rules. So for example, if you add a new lab test for a case that's already been closed by DOH for a hepatitis C case, it will not create a duplicate case, but it will but on submission, when you submit the case, it will append to the existing case. So this will make it easier for your workflow because there will be less duplicates to merge, and then fewer merge requests to our help desk as well. Okay, so we'll go into our testing and training plan a little bit. So we are in the process of our internal user acceptance testing right now with Department of Health and our IT team. That's ongoing. And we plan to open up testing for the external users, including local health departments, hospitals, and labs, as soon as we finish our internal testing. So any users interested in testing should contact CDRSS admin, and I'll provide the email for that at the end. So that way we can reach out to the individuals who are interested in doing our external user testing. And then as far as training, our training features will be similar to currently. So first we will have the option to be trained by the trainer. So we plan to do video trainings for the new system, and then the options for training will remain the same. You can be trained through the trainer or a webinar video training. And some of the materials that we'll be using for training, we'll have a new revamped training manual along with many user help documents to help you navigate through some of our new functionalities, also some quick tips and resources. And then in addition, we plan to have small video clips for each of the various functionalities, and this will be posted on our website as well. So if you ever need reference to how to navigate and utilize some of the features, then you'll have those videos as resources available to you to refer to. And then going into the changes impacting local health departments. So now local health departments will be able to access the export all reports based on your viewing privileges, which is a great feature. And then additional reports training will be available for you all to help you navigate the different reports and the export all reports that you will be able to see. So the disease-specific section I mentioned earlier, this will be utilized to add additional questions related to a specific disease, outbreak, or a special event that may occur. This disease-specific section will be, or questionnaire will be prepared by the state for the local health users to complete. This section will provide more question flexibility as opposed to more standard questions in risk factors, signs, and symptoms. So the section and questions will be customized based on the requirements and the disease primary setup. Some examples that you may see for disease-specific sections, so we would have a typhoid fever questionnaire. Some of the perinatal Hep B questionnaires, questions specifically related to the baby will now be in a separate section for you to fill out, and then also the congenital syphilis CDC questionnaire will also be added in CDRSS. So just to give you some examples, and then we'll also have some questionnaires related to specific outbreaks or investigations that may come up. So these disease-specific questions can be added through even after the system rolls out. And then this just goes over a sample of what a disease-specific section could look like. So this is just a sample that we set up for typhoid. So the questions are specific to typhoid, and then they can be customized based on your responses. So you can have nested questions, and then your responses will determine whether there's additional questions to follow. That covers the changes impacting local health departments and the updates for CDRSS.
Thank you, Della. If you have any questions for Della, please type them in the questions box, and we will try and address them. We have a few minutes for questions.
Okay, so the first question is, we find that a lot of duplicate cases are created when a lab enters new results. Will the CDRSS catch this and automatically update a current or past case to cut down on duplications and the need to merge cases? So I'm going to have Stella Tsai, our CDRSS administrator, answer this question.
Okay, so currently we know there are several, for most of these you will see a lot of duplicates. So for duplicate cases, currently CDRSS does not have the functionality to do the deduplication. But I think we will need to address this from the training. So when people enter the case, first you will need to do the person search. So we will begin to address from the training side.
Okay, the next question is, how can a lab report be added if the case is closed? We wouldn't create a new case. We have to ask for the case to be open to be able to access the case. So how will it be appended if we are adding the lab report in?
Okay, so for the DHSS approved case, you would need to request the help desk to reopen the case for you. For other than DHSS approved case, you should be able to just append the lab's information.
Will you be able to upload any documents into the new CDRSS? We don't have the ability to upload any new documents in CDRSS, but any documents that you have relevant to specific cases, you're more than welcome to reach out to us if they're relevant to the case. Sounds as though investigations are going to be more time intensive with multiple questionnaires to complete. So the questionnaire in the beginning will provide specific training and guidance for how to complete the questionnaires, and some questionnaires that for the disease-specific sections could be as simple as 2 to 3 questions, whereas if some of them are more time-intensive, then we will go through the steps to provide local health departments with guidance. And then now, because our sections are customizable, you may not see as many sections for certain diseases, and then we'll be working with you guys on which information specifically that you need to complete. So we'll provide the guidance for you guys. Okay, next question. Sorry, they're all coming in so fast. When will these changes take effect? As I mentioned in the timeline, we are in the process of completing our user testing right now. And then as soon as our internal user testing is completed, we will be reaching out to local health departments for external testing and then providing training after that. Can we train on our own on a training site? We will still have the similar functionality where you can be trained by a current CDRSS user, but in the beginning, everyone will have to go through the video training since it is a new system, and then you can train using the training site. But you'll be able to see all the videos that we'll offer on your own, and then receive your login for the new system after. Will the new system have a mapping function? Yes, the system will have a mapping function. Labs do electronic reporting. How will they be able to search a person before creating a new case? As we advise all of our users to always do a person search before creating a new lab or a new case, because since our system is patient-centric, this will allow you to see whether the person is already in the system to prevent duplicates. STD program will also be updated. Yes, so CDRSS includes the STD in the communicable disease reporting, so this will also impact those updates. To decrease duplicate lab investigation in instructions such as psychiatric, prison, correctional facilities, the lab enters the facility that they are in, not their home address, which creates duplicate cases. What could be done by the lab to decrease this? This question seems more directed towards the lab, so this wouldn't be a CDRSS related question, so we'd have to contact the lab for this. Are the questionnaires no longer on paper, but now in CDRSS? So this question depends on the disease and the requirements for that disease. So additional information will be provided by the program.
Thank you, Della. That's the amount of time we have for CDRSS questions. Please type the questions that you have. If we have time towards the end of the webinar, we will go ahead and address all those questions. Our next presenter is from the STD program. Deborah Wiesner is our Public Health Rep 1 at our STD program, and she will be addressing the reporting guidelines and investigations of STDs in New Jersey. Deborah. Hello.
Requirements, methods of reporting, forms, investigation, overview, assignment, the PMD follow-up, interview, CDRSS, and questions. So reportable STDs in New Jersey are chlamydia, gonorrhea, syphilis, chancroid, granuloma inguinale, and lithogranuloma venereum. The main ones that we see, of course, are chlamydia, gonorrhea, and syphilis. And the New Jersey reporting requirements are developed from Chapter 57, Communicable Diseases. I've included the New Jersey website because there's multiple information on there, reporting forms, questions, the administrative code, and any information on STDs. All laboratories in New Jersey must report a positive result within 24 hours of test completion. All medical providers must also report 24 hours after receiving a positive laboratory report and diagnosis and treatment. So the methods of reporting are, in CDRSS, everything is reported electronically for the most part from laboratories. Communicable Disease Reporting and Surveillance System manages all the reportable communicable diseases and reportable STDs since 2011. Prior to that, we had a different program. So labs, all laboratories in New Jersey report all positive labs results electronically to CDRSS within 24 hours of test completion. Medical providers may report via electronic transfer, fax, phone, or mail. Results cannot be emailed. We don't have the encryption or the safety measures to accept that. And the fax number I have included, you can see it on the screen. Out-of-state reports, out-of-state laboratory reports go to their health department first. Reports then are forwarded to the client's state health department via Interstate Communication Control Record, or ICCR, which is a system in the process to confidentially share STD information. So that's how we get the reports from out of area, which having medical providers report within 24 hours is a benefit. This can take, prolong the process when it's out of state, so then we get the information quickly and can follow up. Okay. When providers report, we have an STD-11 form that is required that we would like you to send in. However, if you have a report that contains all the information on here, we will accept that. And you can go to the website, newjersey.gov, health, STD, and the form is available there to print out. And it can be faxed in or mailed in. And as you can see on this report, it's very important that we get all this information. If not, we will have to call back and follow up. Patient's name, age, birth date, pregnancy status, especially with a increasing congenital syphilis, that's very important. Gender, race, ethnicity, home address, telephone number, test date, result, and testing laboratory also is very important, because if there's anything missing and we need to follow up, then we know what lab to contact. Date of treatment, medication, and dosage, name, address, and telephone of the provider. Also, on this form, if you have a problem getting the patient and you've attempted a few times and you need help, you can just note that and we will be happy to follow up. So briefly and quickly, that is the reporting guidelines and what we follow to get information in. If you have any questions, I'll be happy to try to answer them. And now I'll move on to an overview of case investigation. All the information I just give you on the reporting guidelines, that goes to surveillance. From surveillance, everything is reviewed, and per the criteria that we have, the case is then put in the system and goes out to the field for follow-up. Cases are assigned to workers by the first-line supervisors for follow-up and investigation if that's warranted. The first process in that is it goes to the worker. Of course, it's reviewed, and then we do a PMD follow-up, which includes reason for visit, past and present lab history, have they had an RPR or a previous infection, when and were they treated, symptoms, treatment, verification of address, telephone, emergency contact, because it gives us another source of maybe reaching this if we weren't able to. If they had any partner information, and referrals that were initiated, maybe to ID doc or to an STD clinic or whatever facility. From then, we will try to contact the patient by telephone, letter, field visit, and proceed to do a confidential patient interview, which includes, of course, our introduction, role, and purpose, social medical history, disease comprehension, elicitation of partners, risk reduction, patient questions, concerns, and follow-up, which would include any referral for follow-up testing, referral for PrEP, if they were HIV negative and in a high-risk behavior, and so on. Every effort is made to do a face-to-face interview so that we have a better rapport and can get better information from the patient. We will do follow-up interviews as we need to, if we need additional information. From that point, elicitation of partners is initiated, and basically the same process. We will meet with them, refer them for testing, do preventative treatment if it's warranted, and refer for any additional follow-up. From that point, the case's information is reported to CDRSS and put in the system, and then sent for review and submission for closure by the first-line supervisors and DHS approved. So, like you said, a brief overview. There it is. Thank you. I've included in my contact information the New Jersey Department of Health, our STD program reporting number, and the fax reports in. And of course, on the front was the website to go to STD to get the form.
Thank you, Deborah. We have time for questions. So if you have any questions on the topics that were addressed today, please type them into the question box, and we have our presenters here who will be able to address them. Who will go ahead and address those questions.
I can't see it. No, is that the question? Okay, our STD reportable is now going to show up under LHD screens. Will the state no longer be investigating STDs? We have currently certain number of DIS trained at the local health department, and yes, some of them are doing investigations, but we also have a team of state DIS who continue to follow and will continue to do investigations, technical assistance, and follow-up in the field. So it's a combination of both at this point. Is public health now going to be doing STD investigations and follow-up? Basically the same thing. We are working together, and at this point we are still handling a majority of them. There are DIS at the local health departments that are doing case investigations. I'm sorry, I can't see real well. Is public health now going to be doing investigations and follow-up? Is the local health department the access for STD cases for their jurisdiction in CDRSS? Is the local health department,
for you.
okay, does the local health department, is that what they're saying?
Yes.
Has access to CDRSS? Yes, local health departments do. They have to go through CDRSS to get access. The STD program, the person who does the STD program does have access. If health officers, administration, whatever, they do basic training and they can see what's in their system for their jurisdiction.
Okay, thank you, Deborah. We have questions for Kim.
Okay, we had a question, how can a close contact get dengue? Pretty much in that situation, we'd be concerned with if the virus had made it into our native mosquito population. So if you had a household cluster of dengue cases, but only one person had traveled to a country with endemic dengue, we would be very concerned that perhaps that initial person had infected the New Jersey mosquitoes, which then went on to bite someone else, in the family. So that would certainly be very unusual. We would be very concerned about that, and that would be something we'd want to be notified about. And again, we would follow up on some vector surveillance activities in that situation. Another question, so a patient does not need to be interviewed in a Lyme disease investigation. We go by the information a physician gives you. That is correct, because again, when we're looking at the case classification, when we're looking at symptoms, the EM has to be reported by a physician. We cannot take a patient-reported EM rash. The other symptoms we're interested in are those late-stage manifestations not explained by another etiology. So again, we have to get that from the provider. The patient cannot tell us if that, first of all, the late-stage manifestations are pretty specific and technical, and they also couldn't really tell us if that was due to Lyme disease or another condition. So we have to get that symptom information from the provider. The other thing we're looking at are the appropriate labs, which are also provided generally through CDRSS. So there really is no need to interview the patient for Lyme disease investigation. So that can save some time. Let's see. Why is there such a high positive false rate for Zika testing? The slide I showed, the very busy slide with the red and blue people, that applies to any lab test anywhere, and as the prevalence of disease goes down, there's always a higher rate of false positive test results. The sample lab test that was used in that slide had very high sensitivity and specificity, so it was a very good test. The tests we have for Zika are not really that great to start out with, and now with the great decline in disease transmission in the Americas, the risk of false positive results is quite high. And of course, having false positive results in pregnant women causes a lot of stress and anxiety. It may result in healthcare procedures being done unnecessarily. And since we don't have a vaccine, we don't have any medication, we don't have any way to prevent congenital Zika, that's why CDC is generally not recommending the routine testing in that group. They are still recommended to be screened for Zika exposure and Zika symptoms at every prenatal visit. They would be monitored through the serial ultrasounds. If an abnormality was detected on an ultrasound, that would put them into the symptomatic category where we would want to do testing, because we would want to see if that testing would help explain the abnormalities that were seen on the fetal ultrasound. I think I'm done. I think there's more.
Thank you, Kim. We have a couple of questions for Della for CDRSS.
So we had a question about Jersey City merging over 100 cases and finding a better method to addressing the address issue, and you requested to talk offline. We can certainly do that. I will reach out to you. So I believe there's one question about including the CDC forms in CDRSS. So this decision would be made by the program and the subject matter expert. Okay, next, the request to get the questions in writing with answers. So we'll type up the CDRSS related questions, and then we can certainly get you guys the answers to that. We can also add them to our frequently asked questions as well. And then the question for providing labs guidance on searching for the patient first to avoid duplicate cases. This is a great suggestion, and we get this a lot. We try to emphasize this when we train our new lab users, but we can definitely continue emphasizing this to our labs, and then come up with guidance for labs to use that, really utilize the first-in search before creating a new case.
Okay. Oh, this is Kim. One additional question. Can we please clarify the patient interview for local health department for Zika? Is this for all approved cases? Yes, we're asking that the cases be interviewed, and again, this is not necessarily the people being tested, but if test results come back that would indicate they have a probable or confirmed Zika infection, we are asking that that patient interview be done to provide the education, and then to also ask if any ill household members were present.
Okay, so the reason for some of the changes to our system is due to technology updates and security reasons. So we don't want you guys to be overwhelmed by the new changes. We will provide the training and guidance for the new system, and then help you guys get through that with the training and videos as well. One question to have a FAQ sheet in Spanish. So we'll discuss this and see if we have the resources to come up with that as well.
Okay, this is Kim. Follow-up question on Lyme. If you have a situation where you cannot get information back from the provider asking if you still do not need to contact the patient, that is correct. And that's basically because nothing the patient can provide us will help us with classifying the case. So if you have made due diligence and have tried to reach out to the provider and have faxed the form and made a phone call and they're just not getting back to you, after the 3 attempts, just document that in CDRSS and close it out as a possible case.
Right, that's all the time for questions we have today. If you have additional questions, you could always send it in, and we will try and get you the answers. We are ending the webinar early, so if well, there are a couple of slides on upcoming training, and we have our CDRSS forums for the WIT coming up. All right, the slides seem to not be progressing for some reason. All right, we do have a copy of the slides. I'm just going to go ahead and mention some upcoming trainings. We have the CD forums coming up. If you have any topics that you want included for our fall forums, let us know. And thank you for participating today. As a reminder, if you're watching as a group, please send me a sign-in sheet so that everyone will be marked off as attended on NJLMN, which means that it will appear on your transcript and will provide the documentation for continuing education credits. There we go. Nurses must complete the evaluation and include your name and email address, and nursing certificates will be emailed to you at those email addresses. When you're sending topics for inclusion, please be specific, and which will help us tailor the program to your specific needs, instead of just saying measles as a topic. If you can be more specific, for example, as measles investigation or case investigation, that would help us narrow down specifically to what you're looking for. And if you're interested in presenting or co-presenting on an investigation or other topic, please indicate that at the evaluation as well. I will be sending out evaluations shortly, and like I said before, our evaluations are very important, and if you can go ahead and address those evaluations with specific questions, we will be tailoring our presentations to those evaluations. So unless you have further questions for us to address or any concerns, we will be ending the webinar. Thank you for participating.